Hello, I'm Dr. Nathan Rudin. I'm a physiatrist, a rehabilitation physician. I practice at the University of Wisconsin in Madison at their pain management clinic. And it is really such an honor to be here and to be speaking to this community for whom I've helped to care. I've been treating people with EDS and related conditions for over 25 years, ever since the first one walked into my office at Johns Hopkins a long while ago and said, "Hey, I have Ehlers-Danlos syndrome." And I said, I don't know a lot about that. And she said, "Well, you will when I'm through with you." And by God, she was right. And so I began to get interested, and to make a long story short, without ever actually hanging up a shingle, as a practicing pain physician in a busy clinic in Madison, caring for hypermobile people is now 75 to 80% of my practice, and probably would be more, except that there were a few other things that they make me do. So one of the big challenges, of course, is figuring out how do we get you all enough care and in a timely fashion. How do we bring that validating experience that Dr. Knight was talking about of actually being diagnosed, of listening? How do we make it so that it doesn't take 10, 15, 20 years and doctors aren't buying stock in Kleenex because we know how long it takes for you to actually get that diagnosis and how overwhelming it can be to wait so long. How do we get primary care involved? So that's really what I wanted to talk about rather. So let's do that. I have no conflicts of interest, commercial relationships, gold bars in my closet, accounts on the Canary Islands, or even financial acumen to disclose. So let's go ahead. Now, Professor Bloom already kind of stole the question I was going to ask about how long it took you to get diagnosed, and we know that it takes forever. I am wondering, though, no, we do not have the right version of this talk up. We got the wrong set of slides. And I don't know what is up with that. Do you have another presentation up there? If you don't, I'll use this one because I don't have much choice. Okay. Looks like I'm probably stuck with this one, so we're going to go ahead. All right. So much for my clever animations on all those other bon mots I was going to put in here. But we know that the average time to diagnosis exceeds a decade for people with hypermobile EDS, and this just doesn't make a lot of sense. I wanted to give you a little bit of the doctor's perspective on why. And one of the reasons is when you go to a medical school, and I went to this one, that's Johns Hopkins University School of Medicine. Dr. Francomano knows it very well. The big dome, it's the place where the gods of medicine live and where they teach us all these wonderful things. One of the big things they told us was, hey, the EDSs are rare. I mean, this is the sort of thing you can file away in your rare disease corner of your brain, only to be exhumed on rare occasion for a board exam or something. And if somebody actually walks in once in your career with this thing, then you can refer it to a specialist. Well, it doesn't work. As we now know, we're talking about somewhere around a 1 in 500 overall EDS incidence. That puts it firmly in the ballpark of prevalences with type 1 diabetes and multiple sclerosis and fibromyalgia and lots of other common conditions. So why aren't people paying enough attention to this? As a result, what we wind up with are a lot of doctors who basically look like this, What? What is this thing? Wait a minute, I think I heard that once in medical school. The gods of medicine told me I could tuck it into a corner of my brain, and I never had to worry about it anymore. Well, if you're really, really lucky, what they will then tell you once they realize they really don't know anything much about it, some of them will indeed minimize it. One of the things doctors hate is saying we don't know, but the fact is there's lots we don't know. And it really is important to admit it to your patient. Validate that. you know? I say it a lot. Hey, I don't know, but you know, I can do my best to find out. And a lot of people will say, well, I got it. I'm gonna send you to a specialist. Ta-da, problem solved, right? Yeah. Because how many specialists have we got? Well, I live in Wisconsin, where we had, at last count, 6 million people, roughly. It's a big place. Not that many people. But anyhow, at 1 in 500, that means over 12,000 EDS patients, approximately. How many EDS physicians do we have? Somewhere in the less than 5 ballpark. Yeah, that's why I have a 2-year wait list personally at this time. And, well, cloning has not worked. And I am training people as fast as I can, but, you know, they don't just show up overnight. So I was discussing all of this with various people, and there's one fella, Dave Rakel, is an authority in integrative medicine. He's the head of our integrative medicine program at UW. And he said, you know, you're never going to get enough specialists to handle everybody that has this condition. We need to move it into the medical home. And makes a lot of sense. Man, this is an ancient version of these slides. Oh, God. This is a really old version. There are 5,600 plus primary care providers in Wisconsin. That's a lot better than less than 5. So what I really want to do is enable primary care providers to recognize and diagnose and start treating HEDS and HSDs in the medical home. That's something we can get going. Because the dirty little secret, the thing that nobody wants to talk about in our field, you know, we sometimes worry we're going to make ourselves obsolete or something. But you know what? While it takes skill and it takes training and it takes being a good physician and being a good listener, diagnosing HEDS and HSD isn't that hard. It's not actually that hard. You know, if you know how to practice sports medicine, you can diagnose it. If you know how to practice spine medicine, you can diagnose it. If you're a physiatrist, you can diagnose it. And there are an awful lot of primary care physicians, especially the ones with osteopathic training, who should be able, as long as they remember how to take a good history, to diagnose this with a few hours of decent, solid instruction. So that's what I'm aiming for. Imperfect slides or not. We're going to soldier on a little bit and talk about it. So the first thing we did, I said, okay, I'm going to run with this. What are we going to do? So I formed a group. We have something called the Center for Clinical Knowledge Management at UW Health Madison, where we write guidelines, evidence-based guidelines, to help guide our practice. So I got a guideline co-author, Lee Skrupke, and I got a whole bunch of reviewers. We had a physical therapist and an integrative medicine person, internists, family medicine docs, pediatricians, rheumatologists, a pharmacist. We got everybody in there we could. And then we surveyed our faculty. And we said, hey, how do you feel about the state of your ability to handle people with hypermobility? Now, I had gone ahead and blown up the type and done all kinds of changes. We're just going to run this through, and I hope that you can see everything. So basically, you know, for each of these little graphs, it goes left to right, where left is strongly agree, all the way to light blue is strongly disagree. So dark blue is strongly agree. So first of all, I feel comfortable identifying hypermobile people. Somewhat agree was the baseline from the 60 plus primary care providers we surveyed. I feel able to diagnose individuals with hypermobile EDS. Well, that is a much flatter curve, leaning towards the somewhat disagree. I feel able to diagnose individuals with other HSDs. Looks kind of similar to HEDS. I feel comfortable providing basic treatment for people with HECS and HSD. Somewhat agree it was pretty good, but there are still a lot of people who are either neutral or somewhat disagree. And then the last one is, I want to learn more. And by God, look at all that blue. Almost everybody wanted to learn more about how to help care for this population. Your doctors do care. They do want to know, but they don't know where to look. We asked them some more questions. I know when to refer people with hypermobility for a genetics consult. Not particularly. I know when to refer them to a specialist in EDS. They don't know much about that either. Access to medical care for hypermobile patients is sufficient? No. So everybody's on board with this. And lastly, I refer people with hypermobility for PT. A lot of them do. I refer them for OT. Some of them do. I refer them for orthotics or braces and splints. Not a very good track record at all. So clearly there are a bunch of things that primary care providers don't know and would like to know more about. And then we asked them specifically, what else do you want to know? If you could have whatever resources you wished regarding caring for this community, what would you ask for? So by golly, they told me. They want clear guidelines. What should we do? They want resources in the electronic health record that make it easier to do the work. They would like lectures. Dr. Rudin, you and your team, please give us videos, come give us grand rounds, whatever, talk to us. And hey, we can point them to EDS Echo, right? We got that out there. They want CME activities. In other words, they want to be able to get credit for having learned this stuff. They want documents for patients. We had already written a number of those, but they are due for revision. They want guides to the physical examination. They want instructions on how to get started managing comorbidities, which are right now the thing that send most doctors running screaming. You know, okay, you're stretchy, we get it. Wait a minute, what do you mean you have mast cell and IBS and POTS and holy cow, I don't know what I'm doing anymore. This is a very common thing. How do we get people doing this? They'd like podcasts. Hey, maybe I can sign a contract somewhere. And they want a guide to bracing and splinting and what is appropriate to order and how do you order it and the rest. So we decided we would start with clear treatment guidelines and with resources in the electronic health record, as well as getting some of the other things on this list started. So that's how we proceeded. Okay. So we put together, over the course of about a year and multiple iterations and reviews and everything else, a consensus care guideline, an ambulatory guideline for how to initially diagnose and manage people with hypermobile EDS and the HSDs. And it's for just about anybody involved in the health professions. The goal is to have standardized evidence-based guidelines. Now, it turns out that is, as in many things in the world of medicine, we didn't have a lot of great evidence, but we went with the best that we had, and we went for expert consensus whenever we didn't have anything clearly firmed up in studies. And our target population is basically anybody 12 and above for this particular set of guidelines with suspected or known hypermobility. And it's broken down into 3 general areas describing the disorders and their clinical features and the coexisting conditions. We have a table with the comorbidities, which got longer and longer and longer, and I'm sure we didn't catch them all, but we've got the comorbidities, as well as characteristics on those and how to get started. Then assessment, what are the diagnostic criteria using those developed by the EDS Taxonomy Consortium, and how to use them, and when to consider a referral to genetics when it looks like it's outside the HSD, HEDS envelope. And then how do we get management started? What are the initial steps for pain management, for rehabilitations, for referrals to specialty care? And we went ahead and we put that out there. Now there's no way, oh, look at that. These really are old slides. Okay. Now, there's no way you're going to be able to read that. But what we did was, besides the introductory text material, going through a narrative, having the tables, is we did put an algorithm together which talks about, okay, what are the symptoms that make us worried that we really should be looking more at vascular EDS or one of the other more dangerous subtypes? What does a marfanoid habitus mean? You know, what are the echocardiographic findings we need to be worried about? What are the family history things we should be worried about? And if they don't have those things, if your patient doesn't have those, how do we move forward? Well, we apply the diagnostic criteria. And depending on the results of that, where do we go from there and how do we treat? Now, since the doctors, just like you, would go blind if this is the only tool they had to look at, we did develop something else. We're one of the hospitals that uses Epic systems for our electronic health record. Epic is actually based in Madison, so we have a little bit of an inside track there. And we have a pathways feature built in where you can build a clinical pathway. And so we did. People can, in any active outpatient visit, open a flow chart, and this is the top piece of it here. I really wanted to show it to you in detail. I had this clever idea of showing it live, but it turns out I would have to put a real patient record up here in front of 2,000 people, and I just can't do that for obvious reasons. But wherever it's blue, you can click and get a resource. So you can get background. We have links to all the references to the actual written guideline document. We have resources that tell us, okay, what are those critical conditions to be concerned about? What are the various things that we need to look for on the examination? And if we're worried about something, we can go over to the right there and we can click on the word echocardiogram, and we ordered an echocardiogram. And we can click on the genetics or the cardiology consult, and we've got the order right in front of us. And then we can go down, take them through the diagnostic criteria. Then what do? We've got pre-populated orders for PT, for OT, for cardiology, faint and fall, for echocardiography, for just about everything else you can think of right there. And we have a list of suggested medications complete with appropriate dosage ranges for different age groups. So it is all there and it is all easy to order. And we have put it out into the wild to see what our physicians do. Thus far, people are telling me they're beginning to put it to use. And I'm just beginning to hear from the people, at least in our system, that there's a little more understanding, a little more advanced knowledge, a little more sensitivity to what people are going through. So, what do we do now? I would have loved to come and tell you all about how this story ended, but first of all, it's never going to end because there's going to be lots and lots to do. But second, we still really have a work in progress. We have done a bunch of stuff. I am doing lectures for primary care providers. The tools were rolled out in April. I am going to record in October a lecture for our medical school curriculum so that every medical student at UW will have at least 1 hour of education on these things. And the hope is that's going to increase. We will revise our patient information documents to bring them up to date. We will resurvey our population at the end of the year. We're going to ask the physicians, where are you at now, and what do we still need to tweak? And we will further publicize and distribute our tools. We will plan a wholesale round of revisions when the new diagnostic criteria come out as part of the road to 2026. Okay, I think that wraps it up. Number one, go Badgers. I had to say that. Number two, thank you so much. Really, it is such a pleasure to be here with such an engaged and thoughtful bunch of people, both providers, patients, families, seeing eye dogs, service dogs, everybody. I'm so glad you're all here. This is a global learning conference. I've only been here a few hours. I've already learned so much from you all. Thank you. Okay.